Hello, everyone, and welcome to the Washington State 2020 Medicaid Integration Summit. Okay. So as we gather virtually from various locations across the state of Washington, we humbly acknowledge that we are all meeting on the traditional territories of hundreds of indigenous tribes. As managed care organizations, we are committed to upholding tribal sovereignty through our dedication to addressing the health disparities amongst AI/AN communities caused by historical and systematic racism. You can find out more about the tribal lands that you currently occupy in the link in the chat. So thank you for joining everyone for the summit today. My name is Stephanie Shushan, and I'm a senior analyst for integrated programs and strategic initiatives at Community Health Plan of Washington. And I will be the host for this summit on behalf of the 5 Medicaid managed care organizations. So before we get started, some housekeeping items. All attendees will have audio muted and video shut off. You can use the chat function for tech issues and comments. For questions to the presenters, please enter those in the Q&A box. So we will track the questions and have presenters respond at the end of the presentation if there's time, or we will be able to track your questions and follow up afterwards if needed. These webinars are being recorded and they will be posted on the Joint MCO website in the coming weeks. Also, you will receive an email with an evaluation from GoToWebinar after the summit. Please complete this to give us your feedback on the summit as a whole so we can improve and inform upcoming trainings that we have. This summit was developed in collaboration with all of the Medicaid managed care organizations. The MCOs have been collaborating over the last 2 years to develop training and resources to support providers across the state as they implement elements of integrated care within their organizations and within their care delivery system. While the presentations within the summit can stand alone as distinct topics, they were developed to highlight some of the important areas of focus in providing integrated care. Reducing stigma around behavioral health is another important aspect of supporting integrated care. So in the GoToWebinar handouts, you can find one of many available resources on recovery-oriented language that you can implement in your practice or in your daily life to reduce stigma and remove stigmatizing language from your care delivery. You will also find the slide decks for today's presentations under handouts. And we will have short breaks in between the presentations as well. So to start off of the summit, the first presentation
Unmuted.
is working with clients with serious mental illness to improve health outcomes. And I'm going to pass it over to Dr. Beth Barara. She is the Substance Use Disorder Medical Director for Anthem AmeriGroup. She is a board-certified family medicine and addictions medicine physician. So Beth, handing it off to you.
Thank you so much, Stephanie. I have the pleasure of introducing Dr. John Kern, and I'll give you a little information about him. Dr. John Kern, he serves as the clinical professor in the Department of Psychiatry and Behavioral Sciences at the University School of Medicine in Washington. He works at the Ames Center at the University of Washington, where his work focuses on the integration of primary care and behavioral health. Participating in a recent national program providing training in collaborative care to nearly 4,000 psychiatrists and primary care providers. A special focus was leading a years-long series of learning collaboratives for providers on collaborative care, leading a community of practice for hundreds of psychiatrists, leading collaborative care efforts across the country, which he is still active. In Washington, he has been developing curriculum and tools to support the medical care of people with serious mental illnesses in behavioral health agencies and providing training opportunities through the Medicaid Transformation Project. Prior to his UW appointment, he was for 22 years the Chief Medical Officer at Regional Mental Health Center in Maryville, Indiana, where he developed and supervised several collaborative care programs and served as the project director for a SAMHSA grant providing primary care for seriously mental ill population. And then, in order to sustain these efforts, developed and served for 2 years as the Chief Medical Officer of a new federally qualified health center, one of the few psychiatrists ever to do so. This permitted the development of an entirely integrated system of community mental health and primary care. He has published on integrated care for psychiatrists, the care for bipolar disorder in the primary care setting, and the medical care people with living with serious mental illness and innovation in the psychiatric clinic. He serves as a collaborative care consultant psychiatrist to the Mental Health Integration Program at the International Community Health Services in Seattle. Thank you, Dr. Kern, and take it away.
Very good. Thanks very much, Beth. Good afternoon, everybody. I am more than pleased to have the opportunity to lead off this event and get you while you're still fresh. And I am very grateful for the opportunity to talk with this audience about this particular form of integration that's most near and dear to my heart. No training without its learning objectives. At the conclusion of this training, I'm hoping that you'll be able to list the medical conditions driving the increased mortality in the seriously mentally ill, to outline the most effective approaches to addressing these conditions, and to describe existing and also potential funding approaches to these efforts. I'm going to talk about integration of primary care outcomes in people with serious mental illness, and this is going to focus somewhat narrowly on the prevention of death by cardiovascular disease. And this is not going to focus generally on every sort of physical condition. And the reason, I hope, will become rapidly clear, which is that this is the area where the disparity in life expectancy is most apparent and I believe most addressable. So I'd like to open with this New York Times article published now a little while ago, entitled "The Largest Health Disparity We Don't Talk About." This is an article by Dhruv Kalar, who is a primary care physician in New York and is affiliated with New York Health and Hospitals. And he wrote this article after having the experience of losing a patient with bipolar disorder with whom he had experienced a lot of psychiatric ups and downs, including suicide attempts, and then had this person die quite young of a myocardial infarction, which was a shock to him and a surprise, and it led him to explore some of these issues. In short, Americans with serious mental illnesses die 15 to 30 years earlier than those without, and this disparity is increasing. And so this is probably the biggest mass media place where one could have seen this, because as he says here, we generally don't talk about it. This is data on the same subject. It has to do with life expectancy and SMI. This is in the US. Data in other first world countries is similar. On the left is the projected life expectancy for an American with no mental disorder, about 77 years. On the right, you will see the projected life expectancy for somebody for mental disorder in the public sector. That translates essentially to people on Medicaid with serious mental illness. And that group, it's 52. So if you do the math, that's 25 years. And this number has been about the same for the last 10, 15 years. Data supporting this and publicizing this came out probably about 15 years ago. And I certainly have been involved almost the entire time on efforts to move this needle, but it's been quite challenging. As I warned you, I'm going to talk about cardiovascular disease because that's where most of the premature mortality is due to. About 60% or maybe more of premature deaths amongst people with SMI are accounted for by cardiovascular disease. And you can see here the rates for the cardiovascular disease risk factors are significantly higher in people with SMI. Every cardiovascular risk factor is more than twice as common. So this is a super high risk population. Not to mention behavioral health behavior issues, most notably smoking. In the United States, smoking has gone down about 50% in recent years amongst the general population. Populations in which it has not gone down are most notably people with schizophrenia and also people with bipolar disorder, in which the percentages have not budged at all. In some studies, the rate of smokers with schizophrenia is closer to 90%. And this has come to be actually another kind of disparity group, a group of unfortunately loyal cigarette customers. And there's even been some suggestion that the cigarette companies are aware of this and that this is in some ways a group that's been preyed on. So far we've got risk of cardiovascular disease, we've got health behaviors, we've got now impact of treatments. People with serious mental illness, adults in particular, are usually treated more often than not with one form of atypical antipsychotic medication or second generation antipsychotic medication. This plot is from a study that's close to 17 years old. There's just been another one recently published this week, which has very similar data, which I didn't have time to update. Basically, on the y-axis, you have weight change. This is in 10 weeks on a quote-unquote standard dose of one of these antipsychotic medications. And you see that these range from medications that cause essentially no weight change to medications that cause a rather spectacular 12-pound or thereabout 11 to 12-pound weight gain in 10 weeks. So a good pound per week if you're taking olanzapine and clozapine. And this has if you work with patients like this and you see them regularly, it is routine. It's common as dirt to see people come in and when they initiate their treatment to just really balloon up. And if you spend any time in a community mental health center, you see folks walking around and it's pretty rare to see somebody at a normal weight. And so the question, as you see here, the question arises, why would you do this? Why would you give somebody clozapine or olanzapine when you could give them ziprasidone or fluphenazine or aripiprazole, which is not associated with an estimated weight change? And the short answer is they work better. This is a really kind of dark irony is that the medications like olanzapine and clozapine are more effective if you are on an inpatient psychiatric unit and you're faced with somebody who is very agitated. This is going to work. It's well accepted. The patients appreciate it. There's not a ton of side effects in the short term, and it's really a tremendously useful tool for everybody, for us and for the patient, in helping people to get settled down. And they are effective in the long term. Using, for example, ziprasidone or aripiprazole in the short term is just not as effective. The problem is that you run into this metabolic problem fairly soon after discharge or even during an extended hospital stay. And folks are uneasy about discontinuing these meds or changing them to another med because they don't want folks to relapse. It's only been in recent years that we've begun to consider the medical implications of these medications over to the right side and start to change our calculations about risk and benefit to include to a greater degree the medical impacts. So this is starting to change. And new medications, to be fair, new antipsychotic medications that come out are you don't get to release a new antipsychotic medication that puts weight on people anymore. But the ones that really do, the clozapine and the olanzapines of the world, are not going away because of their effectiveness. And so this is always something that's on the table with folks that adds significantly to their risk. So so you have this population. They're at risk for at least 3 different reasons. We haven't even gotten to social determinants yet. And so the question is, what can reduce cardiovascular risk, especially things that we can do with populations with serious mental illness? There are a number of studies. There's been a meta-analysis about attempts to reduce cardiovascular risk, and in particular weight in populations with SMI, which is challenging. And some of them have been, I will say, gently effective. There's a strong evidence for the use of 4 interventions so far. One is metformin for obesity, usually that caused by atypical antipsychotic medications, lifestyle modification for obesity, and these are usually very, very structured exercise-based programs. And then tobacco cessation, both varenicline and bupropion have been shown to be useful, and in our hands, we've found those to be surprisingly effective in helping people to stop smoke. And there's an entire literature, which I won't have time to talk about the fact that people with schizophrenia do want to quit smoking, and they do despair of their inability to do so, and they can respond very well to this kind of treatment. The story here is that faced with this difficulty and all these odds, there is a tendency of people working in this area, especially our line staff, to feel like it's just so overwhelming. There's never anything you could possibly do about it. But there are some reasons to think that relatively small changes in risk factors, though lots of risk factors are present, can make big difference in cardiovascular risk. And I will bring your attention to, for example, if you're able to bring somebody's hemoglobin A1C down 1 point, there's a very significant reduction in diabetes-related deaths, heart attacks, microvascular complications. Similarly, with 6 points of blood pressure, which doesn't seem like much, 42% decrease in risk of stroke. Pretty significant changes if you can even move the needle on the risk factors a little bit. The reason I dwell on this, and I show this slide every time I talk to organizations that are doing this or to providers who are doing this, is that this big difference in risk is not apparent to the naked eye. And when you're working with an at-risk population, and they have all the stigmata of someone who has put on often a lot of weight and is not well. When you make this kind of change, it is not apparent to the naked eye. And this can be somewhat demoralizing to patients, and this can be demoralizing to staff people and to people running programs of this kind. And so it's really important to know the difference between how somebody looks and what their medical risk is and whether that has moved. And so it's important to use the data. This is something that we're always talking about on the collaborative care side. And it's particularly true here so that you can sustain a program that does make a difference. The nature of the programs that have been the most effective have been what are called behavioral health homes. There have been a number of different sort of care management arrangements, including the use of nurse care managers, but the most effective ones have been in a health home model, like the Medicaid health home models that you're probably familiar with on the primary care side. The most effective at all, of course, was the Missouri CMHC health homes, which is kind of the gold standard for how this kind of work is done. But there's a number of others that have published successful outcomes, including an organization, Phoenix, in Maryland, Kitsap. And there was behavioral health homes in Washington, which were actually not unhelpful from the physical outcome side, but which have, because of their structure and their financial structure, not been feasible for almost a handful of organizations to continue. But they, as one of them who will remain nameless told me, it's a great way to get patients better and lose money. This is a this is one of the many positive outcomes from the Missouri Community Mental Health Center healthcare homes. This is, for example, and their population was a seriously mentally ill population across the entire state. All of the community mental health centers were engaged to do this, and they had a very robust team, including nurse care managers and case managers and a primary care consultant to work together in a team-based way to address risk factors of the kind we've been talking about. And they were able, for example, I thought I had fixed this math, but obviously this is wrong. They had pushed A1C down about a point. They pushed the blood pressure down. They pushed lipids down. They kept people out of the hospital, and they saved $98 million in the first 4 years for Medicaid. So this has been sort of the gold standard. This was the most effective version of this ever. This program persists. I actually trained their primary care providers and PCPs a couple of years ago. They're still hacking away at it. The general approach to how you deal with a population of people with serious mental illness who need support for their behavior, for their primary care outcomes, is look something like this. And those of you who are familiar with the collaborative care model may recognize this general scheme of a number of multicolored blobs. In this case, there are a set of different blobs than usual. But what they have in common is the need for collaboration of two forms of endeavor, the primary care endeavor and the behavioral health endeavor. And they also have in common the common integration characteristic of trying to do one thing on the territory that usually belongs to the other thing. And so in this case, the Behavioral Health Agency has assumed responsibility for a primary care book of work, and that is the monitoring and the oversight and the support for primary care outcomes. One might ask, why would they do that? Don't they have enough to do with their behavioral health thing that they're signed up for initially? And the short answer is yes, they do have enough to do. The long answer is that they have really only the choice between doing nothing and watching their patients die young, or of doing something. This has not been taken up, and probably is not going to be taken up generally by primary care organizations, for whom this is something of a niche population. It's not a primary concern of the primary care world. Bless their hearts. I ran a primary care organization. They do wonderful work, but this is not what they come to work in the morning to do. And so it's incumbent upon the behavioral health side to do this supportive organizing, monitoring, oversight kind of work. And the way it looks here is analogous to what you see in the collaborative care model. You have a nurse care manager up here. Well, first you have the patient in the middle, of course, and this is intended to be patient-centered and supportive of folks who very frequently have difficulty negotiating the American medical system, and they are in good company, since I also have trouble negotiating the American medical system. At the top, you see the nurse care manager, and there's somebody who's paying attention to data. You're gathering data, you're looking at it in a systematic way in a registry format, seeing who's getting better, who's not getting better, who's getting seen, who's not showing up, and using that data to take what are inevitably limited resources in terms of case management and psychiatric resources and behavioral health resources to address the support of the care of the people who need it the most, or who are most not responding to our efforts. There's usually a psychiatrist and or PCP partner. There's some medical person who's available to offer support to the team that's doing this. And sometimes it's very, very useful to have just very minimal medical oversight. And this is what they did in Missouri. They had an hour a month or a couple hours a month or something of a PCP who would, for example, one example I ran into was an organization that was trying their very best to use a registry and gather data and use it, and they were spending a great deal of provider and administrative time entering all the different indices of a complete blood count. And so what that team needed was permission and advice to focus on just a handful of medical and laboratory indices that were actually important, that were decision makers, and that saved them a ton of time, basically a whole person's full-time work. And so that kind of oversight can often be very useful in that kind of way. Last but certainly not least is the case manager. The case manager is usually a bachelor's level, if that, sort of person, usually young, usually not particularly well trained in medical issues, and the face-to-face person who's actually, as I like to say, the business end of the stick of this team, working with person to support good behavioral health behaviors, to help them engage with the medical system, to help them engage with primary care, and the like, and to provide some face-to-face oversight with how those things are going. This is a hugely important position, and often with the person who's the least prepared. And a lot of our work at the AIM Center during the Medicaid Transformation Project has been closely directed at exactly these folks. We're continuing to work on durable treatment materials for the case manager because these folks need a lot of support. They're often not prepared. They often turn over. It's often a job people don't stay on for a terribly long time, and so they need a lot of support. And that's where in the last year or so we've been working with the organizations doing this throughout the entire Medicaid transformation program. But in the last year, we've been focusing very closely on offering support to those people who need the support the most and who are super important. To branch out to a few related issues, pediatric populations, one would think, well, you don't have to worry about heart attacks and the like. Well, that's wrong. Weight gain is, I will quote, severe and rapid in antipsychotic naive patients treated with second-generation antipsychotic medications. It's far worse in terms of these impacts than in adult patients. And what you see in children is that not only do they put on weight very quickly, but their indices of glucose metabolism and the onset of what start to look like symptoms of type 2 diabetes start almost immediately. Yeah, which is really kind of appalling. A lot of the patients who receive these kind of medications, pediatric populations, are kids with unclear diagnoses, often for explosive kind of behavior, sometimes for autistic-related conditions, sometimes for what are diagnosed as mood disorders. But in any case, they have been fairly widely used, and child psychiatrists have not been adopted and adhering to guidelines for monitoring, weighing these kids, checking their lipids. Their lipids go up, they gain weight hand over fist, and less than 20% of a pretty select group of specially trained psychiatrists are actually doing what they are in fact aware they should be doing. So this is a real concern. This risk is going on. These people are going to hit the fan, a couple decades from now, but they're not getting off to a very good start. With substance use disorders, another kind of organization we've been working with, there are some specific, all of the above, plus infectious disease at higher rates, and lots of folks you see with kind of chronic difficulties with wound care, MRSA, the like, and this is just in addition to the other kinds of things you see with the comorbid mental health conditions a lot of these folks have. One of the questions I was asked to address was for behavioral health agencies, what kind of physical health screeners might one use? Briefly, I think that for the high-risk group is folks who are being prescribed antipsychotic medications, and that picks off pretty much everybody with schizophrenia, a lot of people with bipolar illness, and it overlaps is a very good proxy for those people at highest medical risk. It's not possible to provide a health home kind of intervention for every conceivable kind of illness. In my view, these should be focused on those that create the highest risk and those that are most amenable to manipulation and to intervention. And those, again, the cardiovascular indices. So a physical health screener for an organization that is seeing folks and prescribing for them It's the kind of stuff that psychiatrists and psychiatric providers should be tracking anyway. Hemoglobin A1C, blood pressure, BMI, lipid screening. This should be, if you're getting antipsychotic, you should be getting this stuff, and a lot of it at every visit. So that's kind of straightforward in terms of a screener for high risk. Some other kinds of screeners that have been used in some organizations include assessments for social determinants of health. These include the PREPARE and the DLA-20. But in my view, I think it's fairly straightforward. If you're prescribing for folks, if you're prescribing for people with severe mental illness, the things that you're already assigned to track are a pretty good indicator of who it is you're going to be needing to provide support to. And I will just say that even the most blessed organization with the most resources, this is pretty high demand work. You can't do this for everybody in your population. You're forced to make decisions, no matter who you are and how much money you have, about who you're going to take turns supporting. You have to make some choices about who's at highest risk and who's most likely to benefit. And that's always going to be the case. I ran a primary behavioral health care initiative program for 4 years, and we had more money than I'm even comfortable saying out loud, and it still wasn't enough to treat the hundreds of patients that to support the hundreds of patients that we wanted to support. Once you've, speaking of social determinants of health, once you have actually addressed that, there's still a lot to do. In these kinds of models, social determinants of health are largely addressed, again, by case management interventions, helping people to interact with the entitlement system, the housing system, et cetera. And once again, our case management staff are those people who are the business end of the stick. One of the things I was asked to talk about was what's called the Wellness Recovery Action Plan, which is a very lovely and useful framework for helping people with serious mental illness once they've recovered from an acute illness to stay well. This includes plans for dealing with stressors, crises, building relationships, and this includes physical self-care, which is why I want to talk about it. People with these kind of conditions need to be taking care of themselves physically, and this is one of the platforms for helping that happen in concert with other kinds of self-care. And so this can be a useful tool in this particular area of endeavor as well. Again, working with folks in a productive way, particularly when you're talking about health behavior change, you're talking about what people eat and how they spend their day, and what makes sense to them. If you want them to exercise, what kind of thing is culturally appropriate, who's going jogging, who isn't. You know, there are a number. I think Seattle is certainly, of all the places that I've worked with organizations, it's one of the most sensitive to this. Again, when you're interacting directly with folks, and these are the cultural competency issues are at hand, it's largely the purview of the case manager. Once again, that's the person who's sitting in the room or sitting in the house or talking to the family, and so being skilled up, if you will, around these kind of issues is also one of the steps along the way to actually being an impactful part of a primary care and behavioral health team. In terms of recovery and resilience, so as most of you probably know, recovery is a term used in the community mental health center world, and it basically has to do with a focus on a meaningful life, relationships and activities that are meaningful to the person, as opposed to a focus of treatment on symptom reduction. So in other words, what you do and who you're with, as opposed to whether you're still hearing voices or not. And I think that the reason this has become so important, of course, is a relatively limited and short-sighted view from people like me, focusing on symptom reduction when someone comes in to see you. A lot of people who have meaningful, useful lives and could be considered to be recovered in many ways continue to have, for example, psychiatric symptoms, for example, ongoing voices, or they continue to be voice hearers, and yet they can be resilient, and a lot of good things can be happening in their life. And so having a focus for community mental health organizations to have focus on this is sensible and appropriate and the way to go. This is what SAMHSA, this is the for those of you who don't know, the Substance Abuse and Mental Health Services Administration, the major government agency supporting this kind of work. This is how they define it. So, and you know, they talk about self-directed life, reaching your full potential. These things make sense. However, I think it's difficult to meet these kinds of goals for meaningful life when you're chronically ill or when you're prematurely deceased. And I've worked I worked for 27 years in a community mental health center, and we would see people all the time who had mightily struggled to help stabilize and help get set up in a life that was meaningful, and they would die in their 40s. And it's just really very frustrating. And this, I think that this particular issue has been under emphasized by this kind of recovery community. It's hard enough to move the needle in terms of the philosophy of the way people are cared for, and without realizing what some of the environmental factors are that limit this possibility that have to do with physical health. Skill building around managing physical illness and interactions with the medical system are something that we've been spending a lot of time trying to help folks learn to do. These kinds of skills about interacting with complex and refractory organizations and institutions can be generalized to improve coping in other kinds of life. And so we spend lots and lots of time talking about dealing with, you know, the medical system. And I have heard pushback from folks saying, you know, there's more to life than the medical system. And this is true, of course. This is my rather narrow outlook. And yet there are lots of kinds of institutions that one has to deal with, and these kinds of skills can translate. Okay. Takeaways. I think probably by now you understood that people with serious mental illness are at extremely high risk for early death from cardiovascular disease. The kinds of ways that we have approached changing this and mitigating this risk have not been a overwhelming roaring success, but organized approaches can work, particularly if you have adequate funding to support this work. At present, in the state of Washington, I wrote it twice, in the state of Washington, these approaches are not funded. Organizations do not really have an adequate funding stream to do this work. Behavioral health agencies are not able to bill for care coordination for adults. And the kinds of funding that on the primary care side, things like chronic or complex care management that permit this kind of work with patients on the primary care side are not available. And so this has been a real obstacle in our work with behavioral health agencies over the last several years. We work with them, we teach them what I taught you today, and we work with them on ways and abilities and formats and strategies for mitigating this kind of risk, but they don't have a way to pay the people to do the work. And a lot of these programs that we have started or assisted to start have kind of died on the vine. And I think that this is a real concern. They're not going to be able to do this with the funding that they have in place now for their behavioral health activities. And so right now, I think that the impact of what we've learned about approaching these kind of problems is going to be somewhat limited by this. This is not limited to Washington. This is true in many states, but this is why you don't hear about it happening more, in my opinion. Okie dokie. So we're at the end of our presentation, and we're ready for questions.
At this time, we do not have any questions that have come through our chat box. So feel free in the audience to put in the question and answer box if you do have a question. We have a few minutes. Well, thank you very much, Dr. Kern. Oh, we do have a hand raised.
Oh, okay.
One second. We do have one. Dan, are you unmuting?
Yes, I've unmuted. So Mohammed, I tried to unmute you, but you need to unmute yourself because you are self-muted at the moment. All right, so it looks like some technical difficulties there. We will take a question. There are some questions that have come into the chat. Let's see. Is there a task list that case managers could follow?
A task list. I think that the way this kind of work has generally been done is that it's a team-based kind of model, and what's usually been done is to have a team, including the case managers and often for example, the psychiatric provider and a nurse care manager get together and with the data for a team and figure out who's doing well and who's doing poorly and who hasn't been reconsidered in a while, and figure out, for example, what might need to be done. Somebody might need to have their make sure they're taking their meds, make sure they're getting to their appointment, make sure things are happening, find out what's happening with their housing, maybe offer some teaching or support on healthy or health behaviors. In other words, any one of an array of problems. And then in some ways what the case manager has is marching orders to do one thing or another, as opposed to get to the person and say, okay, now here's my list of many things I must do. There's a long array of possible interventions. I actually have constructed a job aid for this kind of thing, what you do when your patient's not getting better. And there's a whole array of different ways you can get yourself into trouble and different ways that a case manager can intervene. And it's a matter, and I think that one of the team functions is to figure out what's that going to be. And then, the case manager is in some ways sent forth to execute. But in terms of a list of possible ways of intervening, depending on, which are dependent on different causes of difficulty, we have constructed some things like that. But in general, on the ground, the number of published and regularly available tools and information about this particular kind of integration everywhere across the country is still pretty thin. This has not been widely taken up in the way that collaborative care has been, and so that's why we've been focusing on doing this work.
Okay, we do have additional questions that have come in.
Great.
Next, I know that we have a future discussion around payment models, but what payment models can you suggest to improve physical health outcomes?
I will talk about a couple. One has been, the notion of the Medicaid transformation project was that there would be support for helping organizations to build infrastructure and get skilled up on focusing in a value-based payment world. And I think that that's something that in a lot of ways hasn't happened, and that organizations, behavioral health organizations that are doing this are not, they're not in a position to access non-fee-for-service funding or additional medical funding to address these medical issues. That those two are still siloed. So that would be, that would certainly be one, if a behavioral health agency was in more of a whole or a more realistic global health or global payment system, where they could actually, for example, demonstrate their value in terms of improving healthcare outcomes. In most of my conversations with payers in the last couple of years, there's been a lot of questions about, well, is there going to be medical cost offset, and if we do this for these folks with serious mental illness, will they end up costing less money in the long run? And I don't know. That has been not robustly demonstrated. There have been some efforts, like the Missouri effort, that clearly saved money. There have been others that haven't. But that kind of demand is something that's not. It's a demand that's not made for other kinds of healthcare. When there's a new cardiovascular procedure or a new cancer chemotherapy, we're not asked if it's going to defray other kinds of costs, and I think that there's a parity issue there. So I think that this is clearly a group of people who are not doing well. There's a healthcare disparity here, and it's possible that dealing with it in a preventative way could make a difference. And I think that could be covered in the way that other kinds of chronic care are covered on the medical side, with either with a global kind of payment model or with some kind of chronic care management code. And that does exist in, there are global payment models that exist in what's called the CCBHC, or Certified Community Behavioral Health Clinic model, which is still sort of a pilot project out of HRSA, where there are what you could think of as a federally qualified behavioral health center. That's what they originally would be called, but basically it's a behavioral health organization that works on a cost plus funding in the way that a FQHC does. And then that's a way of making it happen. They can actually provide that kind of additional care coordination under that model. And that's been, that's it's not a pilot project anymore. It's a funding stream that's up and running from SAMHSA, and we're hoping on the behavioral health side that will expand further. I think it's in 10 states now.
Thank you. We also have a few questions around co-occurring substance use disorder, and if you could touch on how that's impacted with your research or what you've seen.
Yeah, we did talk a little bit about it. This has been, I will confess, the specific needs of people who are specifically identified as having primary substance use disorders. This is something that we've been paying more attention to in the last couple of years. There is evidence that populations of folks with substance use disorders and opioid use disorders are at much higher medical risk, and of course, people with opioid use disorders more so than anyone. There has not been a body of work of this kind with a structured team-based approach to medical risk in this population by organizations that are substance use disorder focused organizations. So if you, on the other hand, if you run a community mental health center or what's in Washington called the Behavioral Health Agency, you see folks all the time. The comorbidity of substance use disorder in people with serious mental illness is very high. And I can only say that it's been a somewhat neglected aspect. We've had so much trouble hitting the marks we'd already begun with, that adding this additional group, on one hand, didn't seem that feasible. On the other hand, their folks are, and there the risk is. We talked about, of course, the risk of overdose is its own thing, but then comorbid disease. There's all the same comorbid diseases. There's all the same cardiovascular risk, and there's the additional risk of infectious diseases and the like. So I think the best way that this is dealt with is in a parallel way to what I've been suggesting, and I think that this is starting to happen this is I believe starting to be part of what folks are thinking about on the OUD side when you're working with care navigators. But I think there's still room for that to be strengthened.
And that kind of builds into a couple questions we have received around the case manager role and the innovative ways they can assist and be involved. There is a question about how to decrease the burnout and keep them in the position, and then also any thoughts around making their work billable.
Well, in terms of the sustainability of the case manager role, it's a demanding role, working with folks who are not always the most amenable to modification of their behavior, and who don't always live in the nicest circumstances. And we send our least prepared, least educated staff to go out and do that. And so they need a lot of support. And I think that if nothing else, I've felt when directing programs like this, that one of the things I wanted to do, and I hope this came through in my comments today, is to draw a red line around what those folks do and point out how it is the most important and the most impactful thing that people do. One of the things that I always quote is Joe Parks, who is now the medical director of the National Council for Behavioral Health, but was the director of the Missouri Health Home Project. He says that all meaningful behavior change occurs in the context of a personal relationship, and I think that's absolutely true. And so one thing is to offer whatever support you can, which is what we're actually working on right now in terms of educational support and functional support and job aids. We're working right now on creating a series of durable training materials that will be available after the Medicaid transformation program is over to be of the highest quality we can possibly manage, to be available for folks who are doing this kind of work, to give them some really on the ground skills, and to repeatedly, in addition to repeatedly emphasize the importance of what they do and the fact that what they do is really, though they often can't see it, and though change is not often visible to the naked eye, what they do makes a huge difference. And often you don't know that, you can't see that. So it's important to keep pointing that out.
So John, we are about time, but thank you so much. We have a lot of questions that came in, and we will be tracking those and compiling those and getting responses back to people. I think John also works with the AIM Center, so he can be reached through information on the website there, and they are happy to work with your practices and figuring these workflows and processes out. So thanks so much, John. So Next presentation, so we're gonna have about a 5-minute break, and at 12 o'clock we are going to start the presentation, Behavioral Health into Primary Care. So opposite setting of John has been presenting on. So we will see you back here. Please feel free to just stay logged in if you plan on joining that webinar as well.